housewife presented with history of swelling of the hand to us since 8 months. To make the history brief, she had a dactylitis and she was being treated for dactylitis with steroids outside, and she presented to us with swelling in the finger, which was associated with discharge. Associated with the discharge. This is the photo of the same patient showing dactylitis with a ulcer which is having a purulent discharge. She was being treated with steroids for the same outside since last 8 months, shopping almost all the doctors, all the specialties. And just when Dr. Chandrasekhar saw this patient, he just told that this is a complex condition, and he asked me to see this patient. I had never seen this. I thought of some infective etiology at the first diagnosis itself, but I thought it could either be fungal, tubercular, or some other etiology. But sir, in his mind, as a first diagnosis, tubercular dactylitis, just a simple smear taken from the first showed AFP, which was 4+. Patient was started on ATP, and now patient is doing better. This is just to bring to notice that tubercular dactylitis is still very common. In the sense, it should not be missed. This is a carry-out message. Then the next one. This is photo of same patient. X-ray of the same patient also showed some lesions in the chest, which was suggestive of fluffy shadow, which was suggestive of tuberculosis, which has disseminated. Probably the steroids which were introduced caused the dissemination of tuberculosis. So always tubercular dactylitis has to be kept in mind whenever dactylitis which is not responding, which is recalcitrant to treatment, has to be always kept in mind. I think sir also wants to comment few things on this.
What was the diagnosis is something which is being repeatedly told by all our senior faculties all throughout our MBS. The X-ray of the hand, of course, I think we couldn't. It almost shows not much of changes in the X-ray of the hand, except the dislocation of two of the metacarpophalangeal joints, but that's also correctable dislocations. This is one of the very common treatable conditions because it was surprisingly at the periphery 6 months of moving around. I think she had a file as thick as of quite a big notebook with many reference across various diagnoses intertwined, with steroid being put as a last possible chance to save up the patient. That made even the tuberculosis to appear even in the chest. So the diagnosis could have been a little more simpler if a thought of a tubercular dactylitis could have been taken. There are a few differential diagnoses.
And there could be sarcoidosis or seronegative psoriatic arthritis, which is commonly thought of, or could be gout, but unlikely in the upper limbs. So, with very few differential diagnoses, tubercular dactylitis has to be considered seriously in such patients. Coming to the next case, she is a 22-year-old female presented to us with sagging of the nose. This is a bony part of the nose, and this is the cartilaginous part of the nose where we see the sagging here. The cartilage is the one which is predominantly affected here. She was referred to us with multiple joint pains, and unfortunately she had a gangrene 3 years back, for which she had undergone an amputation. Basically, she was referred when she had joint pains, and when we evaluated her, we found that she had associated scleritis, she had perichondritis of the ear, and we made a diagnosis of relapsing polychondritis in such patients with peripheral vascular disease. We confirmed by Doppler that she also had a peripheral vascular disease also, and we treated her with steroids and methotrexate. She was better, But once she was in regular follow-up, and what happened during the next visit, like after 3 or 4 months, even on steroids, she developed claudication in both the upper limbs, and she had a carotid GUI. So we did a Doppler showed involvement of both the carotid arteries, involving both the carotid arteries. So it was a relapsing polyarteritis, or whether it is a large vessel vasculitis, tachyarthritis in this patient. She requires still regular follow-up. She is on follow-up on steroids and methotrexate. I would like to ask Dr. Narasimhan to comment on this.
Shallow nose deformity, word proximity toward syphilis, but syphilis no more seen now. Janssen we see, relapsing polychondritis we see, and vigorous gallbladders we see. And here epicalite is another class, very classic of relapsing polychondritis. Relapsing polychondritis, already one limb has been amputated for vascular insufficiency. Again, she developed upper claudication. Now I would like to consider the first possibility antiphospholipid antibody syndrome. And other thing is large vessel vasculitis rarely people are described to cerebral people. So gain cell artery, thigh cell artery, they are described for the case report, not as regular features. But I am very concerned about primary vasculitis and secondary vasculitis and antiphospholipid antibody syndrome. I would like to definitely like to have antibiotic antibodies and PTAPPT
Negative, sir. If failure was of this
negative. Then I still want angiogram, MRI angiogram and distal angiogram, distal subtract angiogram. Definitely we get answer. And other thing, recently 6 months back in one of our department general club, they were reported gain cell arteritis and polychondritis in the same patient, but they are case report. This is main one of the case.
Reportable case.
relax per se itself. But here we have patient has other associated small vessel, medium vessel vasculitis also associated, which is quite rare.
Case report of
Yes,
vasculitis
case report,
and relapsing polychondritis. Classically, what you see, eye involvement, hearing, and throat arthritis. Wherever cartilage is there, it gets involved. And there is a number of relapsing polychondritis. Here we see one or two, not many. And again, vasculopathy in relapsing polychondritis is very common. Angiogram,
Angiogram is not very nice, just
I think sensible should be angiogram. It's
Class factor is appreciated. We will definitely get that.
send us to do free.
Sure.
Interesting one. Very interesting case. This is very important.
joint pain since when she presented, she had joint pain since 3 months involving bilateral shoulders, significant weight loss, myalgia. She had a history of TIA. There was also a history of loss of appetite. In an elderly patient, with all these things, we thought of a malignancy could be one of the possible etiology in such patients. We investigated her, the area was positive, and X-ray also showed some juxtaarticular osteoporosis. All the other investigations which were done were almost normal. She was put on NSAIDs with very minimal response. As she had no reduction in pain, and also one day she presented with very severe pain, which made us to investigate her with to rule out malignancy seriously. So we did a PET, whole body PET CT scan, which showed increased uptake in multiple joints with suggestive of synovitis and increased uptake in the aorta with a atherosclerotic plaque on the right side. And it was reported that patient has subclinical vasculitis by the amount of uptake in the vessels. We diagnosed her as polymyalgia rheumatica and started her on steroids with methotrexate. Patient is doing well, and patient is also has gained weight and is able to do all the activities. But still we are following up the patient to look for development of any other malignancies. So one thing to be brought to notice is elderly patient coming with vague pains, especially with the proximal pains, always look for malignancies. And as we have the facility of various investigations like PET-CT, which can identify occult malignancies, which can even identify few of the rheumatologic diseases also. That should also be kept in mind, so that we don't miss treatable conditions.
Last